This begins Chapter 2, Lesson 2.3. Bloodborne diseases. The biggest threats to healthcare workers are hepatitis B, hepatitis C, and HIV. Hepatitis is much easier to transmit than HIV. The chances of contracting an infection after a needle stick for hepatitis B infected blood is 6% to 30%. For hepatitis C infected blood, it's about 2%. And HIV infected blood is only 0.3% after a needle stick injury and 0.09% after a mucous membrane exposure. Hepatitis B is an infection of the liver caused by the hepatitis B virus, HBV. The most common means of transmission in a healthcare setting are through blood or blood components, such as serum or plasma. Healthcare workers are the most likely to contact Hep B through needle sticks. Again, that's a 6 to 30% chance of developing, and then cuts with contaminated sharps. Post-exposure prophylaxis. After exposure to hepatitis B virus, appropriate and timely prophylaxis can prevent HBV infection and subsequent development of chronic infection or liver disease. The mainstay of post-exposure prophylaxis, or PEP, is the hepatitis B vaccine, but in some circumstances, hepatitis B immune globulin can be recommended in addition to the vaccine for added protection. The hepatitis B vaccine, employers must offer the vaccine series free of charge to all employees within 10 days of their initial employment, and also anybody who has had or will have occupational exposure. Exceptions are if the employee has previously received the vaccine series, if the employee is immune to Hep B, and this would be proved with a blood titer test. If the vaccine is contraindicated for medical reasons, or any employee who declines must sign a waiver, and this is filed in the employee's OSHA record. And any employee who declines may later request the vaccine at any point in time, and they can receive it free of charge. Hepatitis C is an infection of the liver caused by the hepatitis C virus. There is no vaccine available for prevention of hepatitis C. The most likely means of contracting in a medical office would be a needle stick or other sharp injury. Chance of contracting is much lower than hepatitis B. It's down to about 1.8%. And 15 to 25% of people clear the virus from their bodies without treatment. HIV, human immunodeficiency virus. So first we'll talk about HIV, then we'll also talk about AIDS. Okay, AIDS is the acquired immunodeficiency syndrome, AIDS. This is a chronic disease of the immune system, which eventually destroys the body's ability to fight off infection. And AIDS is caused by the retrovirus known as HIV. It's an RNA virus that inserts a DNA copy of its genome into the host cell in order to replicate. So HIV is the virus and the infection, and AIDS is a condition which actually happens to be stage 3 of the HIV infection. So it's one of the later stages in the infection. So HIV is not transmitted through casual contact, such as hugging a family member, holding hands, anything like that. It's spread primarily through sexual contact, sharing needles with infected individuals, and untreated HIV-infected women can transfer to their infant during their pregnancy, during birth, and through breastfeeding. The risk of AIDS is low to health workers. The risk after exposure is 0.3%, so that means 1 in 300 workers who is exposed will contract it. Because HIV is unstable, it's not easily transmitted that way. But it's extremely serious, so it warrants strict adherence of OSHA bloodborne pathogen standard by all healthcare workers. Most HIV carriers are asymptomatic. They may be unaware of their infection. Precautions minimizing risks of exposure to blood and body fluids should be taken with all patients at all times. So this is what we mean by standard precautions. It's a means of protection from all bloodborne pathogens such as HIV, hepatitis B, hepatitis C. And it's standard because we use the same exact level of protection with every single patient that we come in contact with, regardless of whether we know what their status is, HIV, Hep B, Hep C. You basically treat every patient as if they have it. So this is from the CDC. If you download the slides, you can click on the link to get more information regarding the CDC's HIV and occupational exposure. So the risk of occupational HIV transmission varies by the type of exposure, but if you get splashed with bodily fluid that is HIV infected, it's pretty near zero to actually get transmission, even if there's blood in them. If fluid splashes to intact skin or mucous membranes, extremely low risk, even if blood is involved. And if you get a percutaneous needle stick injury, it's still less than 1% likely that you will be transmitted HIV. Okay, let's watch some videos.
The name HIV almost always refers to HIV-1, the more virulent and infective type. The human immunodeficiency virus, or HIV, targets cells of the immune system. When the immune system starts to fail, this is termed immunodeficiency. In the final stage of the disease's progression, a patient is said to have acquired immunodeficiency syndrome, or AIDS. AIDS is not the virus, but rather a set of symptoms that result from the virus. It is defined as either having a T-cell count below 200 cells per millimeter cubed of blood, or as having HIV and at least one opportunistic infection associated with AIDS, regardless of T-cell count. An opportunistic infection is an infection caused by pathogens that would normally not be a problem, but which take advantage of an opportunity, such as a compromised immune system. HIV targets CD4 positive cells, in other words, cells that bear the CD4 glycoprotein on their membrane, such as regulatory and helper T cells, monocytes, macrophages, and dendritic cells. CD4 is a co-receptor of the T cell receptor, allowing T cells to communicate with antigen-presenting cells such as dendritic cells. In order to understand how HIV impacts the immune system, we must first understand the difference between innate and adaptive immunity. The innate immune system consists of generalized barriers to pathogenic invasion. This includes physical barriers like your skin, cell-destroying stomach acid, the inflammatory response, and cells like macrophages, neutrophils, and mast cells that recognize molecules common to pathogens. Meanwhile, the adaptive immune system brings out pathogen-specific weaponry. This response is thanks to B and T cells, which recognize antigens, bits of a pathogen that allow for its recognition. When dendritic cells, a type of antigen-presenting cell on the bridge between the innate and adaptive immune systems, enter lymph nodes, B cells produce antibodies to bind the specific invader, marking it for destruction by other cells. There are 4 kinds of T cells, and the relevant ones here are cytotoxic and helper T cells. Cytotoxic T cells bind and lyse the pathogen. Helper T cells are necessary for the activation of both cytotoxic T cells and B cells, so without them, the adaptive immune response can't be activated. Antibodies don't get produced and infected cells aren't lysed. Unfortunately, helper T cells are CD4 positive and the main target of HIV. As the infection progresses, there is a substantial loss of these cells. The immune system fights back by producing more T cells, some of which differentiate into helper T cells. This fight for supremacy continues for years, until the virus eventually tips the scales. The body loses its ability to produce T cells, and even the weakest pathogens become problematic.
If you like this video, please like and subscribe. It would help.
Here's part 2.
HIV is a single-stranded positive-sense enveloped retrovirus. Each virion is made up of a lipid bilayer with a capsid inside it containing 2 copies of an RNA genome, as well as reverse transcriptase, protease, and integrase. The viral envelope is derived from the lipid bilayer of a host cell and has glycoproteins sticking out of it necessary for the virus to infect cells. These glycoproteins, GP120 and GP41, together form GP160. A trimer with 3 pairs of GP120 and GP41 glycoproteins forms an envelope spike complex. The capsid is a protein shell that protects the genome. Reverse transcriptase, integrase, and protease get to work once HIV is inside a host cell, and we'll get to that soon. First, let's follow HIV's life cycle. Infection most commonly results from sexual contact, though it is also possible to contract HIV from contaminated needles or, in rare cases, from blood products such as blood transfusions. It is also possible for babies to get HIV from their mothers while in utero, or from breastfeeding. Fortunately, you can't get HIV from casual contact, the air, water, or mosquitoes. How does HIV enter cells? GP120 binds the CD4 glycoprotein. This triggers a conformational change that exposes binding sites for a coreceptor, either CCR5 or CXCR4. CCR5 is found on T cells, macrophages, monocytes, and dendritic cells, while CXCR4 is found exclusively on T cells. Anyway, further conformational changes reveal the fusion peptides of GP41. These fusion peptides are inserted into the host cell membrane, and HIV's viral envelope can now fuse to it. The presence of both the CD4 glycoprotein and its coreceptor are essential for HIV to enter a host cell. Since almost all HIV-1 isolates are successfully transmitted using the CCR5 coreceptor, people with homogeneous mutations in their CCR5 are basically immune to HIV, and even heterozygous mutations can slow the infection's progression. HIV's single-stranded RNA gets reverse transcribed by reverse transcriptase into a double-stranded piece of DNA. As the reverse transcriptase goes about this process, the capsid uncoats. The double-stranded piece of DNA associates with integrase and is brought into the nucleus. There, integrase integrates the HIV DNA into the cell's genome. This DNA is termed proviral DNA, and viral RNAs get transcribed from it. Many other retroviruses wait until mitosis, when the nuclear membrane is broken down, to get their genome integrated. But HIV interacts with proteins of the nuclear pore and gets admitted. Once HIV's proviral DNA is integrated into the host cell's genome, it cannot be eliminated except by killing the host cell. The viral DNA is transcribed and translated into viral polyproteins, which move to the surface of the cell and form an immature HIV. This HIV pushes itself out of the cell, grabbing part of the cell's membrane to form the viral envelope. Protease comes in and cleaves the polyproteins at 9 cleavage sites to create mature protein components. And now we have a new HIV virion.
If you like this video, please like and subscribe.
And here's part 3.
There are 3 stages of HIV infection: the acute infection, the chronic or latent phase, and AIDS. The acute infection begins when HIV enters the body and establishes an infection. Some people get no symptoms during this period, though typically there will be flu-like or mononucleosis-like symptoms that decline over 1 to 2 months. Initially, replication occurs within immune cells at the site of infection, or in peripheral blood mononuclear cells. At the start of the infection process, HIV is usually R5 tropic, or M tropic. Viral tropism is viral preference for particular coreceptors. M-tropic HIV is a strain of HIV that enters and infects cells that have CCR5 coreceptors. So again, T cells, macrophages, monocytes, and dendritic cells. HIV is infamous for its high rate of mutation. HIV's RNA is about 9,200 nucleotide bases long, and reverse transcriptase introduces a mutation about once per 2,000 incorporated nucleotides. With the rate of viral replication being so high, a second strain of virus sometimes develops: X4 tropic or T tropic HIV. T tropic HIV binds to the CXCR4 coreceptor, which is found exclusively on T cells. This is very bad news, as it speeds up viral progression. M tropic and T tropic strains can coexist in the body. There is also another reason why HIV might start off as M tropic and eventually develop into a T tropic strain. CCR5 is generally expressed by memory T cells, while CXCR4 is expressed by naive CD4 T cells. Normally, memory cells divide about 10 times faster than naive CD4 T cells. Hence, T-tropic virus would be disadvantaged during early infection. However, as the disease progresses, naive cell division is as frequent as that of memory cells. That is when there tends to be a shift in tropism. Sentinel dendritic cells in mucosal tissue are one of the first cell populations that HIV encounters during sexual transmission. They are important in establishing a successful host infection from a small viral pool. HIV cannot productively infect the dendritic cells, since they have low levels of the receptors HIV needs to enter, and HIV gets degraded if internalized. However, dendritic cells capture virions that are later transmitted to T lymphocytes. HIV's GP120 sticks to the adhesion molecule DC sign and other C-type lectin receptors on the surface of dendritic cells. The virus is carried around in deep folds in the dendritic cell's surface. Dendritic cells travel to the lymph nodes, where there are tons of T cells, HIV's ideal target, and the HIV begins to spread like wildfire. One way in which dendritic cells can transfer HIV to T cells is via an infectious synapse, in which the dendritic cells concentrate intact virions at the point of contact with a T cell, and induce recruitment of CD4 and CCR5 on the T cell. The bulk of CD4-positive T cell loss occurs in the first few weeks post-infection. The greatest number of casualties occur in the intestinal mucosa, where most of the body's lymphocytes occur, and where the majority of T cells express the CCR5 coreceptor. There is now a big spike in HIV replication and the amount of virus in a patient's blood. At this time, there can be several million viral particles per milliliter of blood, and there is a large drop in circulating helper T cells. This acute viremia, in other words, virus presence in the blood, typically results in the activation of the CD8-positive cytotoxic T cells, as well as B cells. The cytotoxic T cells kill infected cells, and B cells produce antibodies. This counterattack lowers the amount of viral replication. T cell counts rebound, though not to pre-infection levels. The infected individual now enters the chronic phase. During the chronic stage, little virus is detectable in the peripheral blood. However, HIV continues to replicate, causing general immune activation. Dendritic cells secrete inflammatory cytokines and interferons, which alter T cell proliferation and differentiation, contributing to the immune dysregulation characteristic of the chronic stage. However, the immune response to HIV is not strong enough to stop viral replication from continuing within lymphoid tissues. Meanwhile, macrophages serve as long-lived reservoirs of virus, resistant to drug treatments and to attacks from the immune system. Infected macrophages accumulate large internal vacuoles containing virus. These vacuoles can lounge about inside the macrophage or travel into the plasma membrane, releasing their viral content into the extracellular space. Reasons for dropping CD4-positive T cell counts differ in the acute and chronic stages. After initial infection, T cell depletion results from HIV-induced cell lysis and the killing of infected cells by cytotoxic T cells. However, at the chronic stage, generalized immune activation, combined with the gradual loss of the ability of the immune system to generate new T cells, results in a slow decline in T cell numbers. And now we come to the final stage of HIV infection, AIDS. A healthy level of T cells is 500 to 1600 cells per millimeter cubed. When T cells fall below 200 cells per millimeter cubed, the immune system is severely compromised. With the emergence from latency, there is a loss of normal lymph node architecture, resulting in persistent generalized lymphadenopathy. Opportunistic infections become common. Apart from weight loss, chills, fatigue, and a persistent fever, AIDS patients suffer from constant diarrhea from infectious parasites, recurring pneumonia, and fungal infections. Certain cancers that are normally rare, such as Kaposi's sarcoma and non-Hodgkin lymphoma, start to cause lesions of skin and other soft tissues. In the end, people don't die from HIV. They die from infections that a healthy immune system would fight off. Although there is currently no cure for HIV, antiretroviral medications can manage levels of HIV, keeping T cell counts high enough to prevent the infection progressing into AIDS. This treatment is not a single medication, but a combination of drugs. Without treatment, the average survival time after infection is 11 years, and after diagnosis of AIDS, 3 years. With daily access to medication, HIV-positive people can expect to live almost as long as those without the virus, and are less likely to infect others.
If you like this video, please like and subscribe. It would help me make more.
Okay, so that ends our lesson 2.3.